Welcome back. In this section, we're going to be talking about soft tissue injuries. Topics we're going to be discussing are going to be soft tissue, closed chest wounds, open chest wounds, treating specific types of open wounds, burns, electrical injuries, and dressing and bandaging. We will start out with soft tissue injuries. Soft tissues include the skin, fatty tissues, muscles, blood vessels, connective tissues, membranes, glands, and nerves. As you can see in this diagram, you can see the skin, the fat, the muscle, the blood vessels, the membranes, the bone, which is the hard tissue, the nerves, and then the organ itself. So the major functions of the skin. First one is protection. The skin is a barrier that keeps out microorganisms, debris, and unwanted chemicals. The underlying tissues and organs are protected from the environmental contact. The surface of the skin also provides a home to millions of microorganisms designed to defend against any unwanted germs. This population of helpful bacteria competes and balances against an overpopulation of harmful organisms. Next is water balance. The skin helps prevent water loss and stops environmental water from entering the body. This helps preserve the chemical balance of the body's fluids and tissues. Next is temperature regulation. The blood vessels in the skin can dilate to carry more blood to the skin, allowing heat to radiate away from the body. When the body needs to conserve heat, these vessels constrict to prevent heat loss. The sweat glands found in the skin produce perspiration, which will evaporate and help cool the body. The fat is the part of the skin that serves as the thermal insulator. Next is excretion. Salts and excess water can be released through the skin. And shock absorption or impact. The skin and its layers of fat help protect the underlying organs from minor impacts and pressures. The skin has three major layers: the epidermis, the dermis, and the subcutaneous layer. The outer layer of the skin is the epidermis. The outermost epidermis is composed of dead cells which are rubbed off or sloughed off and then replaced. The pigment granules of the skin and living cells are found deeper in the epidermis. The cells of the innermost portions are actively dividing, replacing the dead cells of the outer layers. The epidermis contains no blood vessels or nerves. Except for certain types of burns and injuries due to cold, injuries of the epidermis present few problems for the EMTs. The layer of skin below the epidermis is the dermis. This layer is rich with blood vessels, nerves, and specialized structures such as sweat glands, oil glands, and hair follicles. Specialized nerve endings in the dermis are involved with the sense of touch that registers cold, heat, and pain. Once the dermis is open to the outside world, contamination and infection becomes a major problem. Such wounds can be serious, especially when accompanied by profuse bleeding and intense pain. The layers of the fat and soft tissue below the dermis are called the subcutaneous layer. It's the shock absorption and insulation are major functions of this layer. Again, when these layers are injured, there are problems of tissues and bloodstream contamination, bleeding, and also pain. Here is a diagram that shows you the epidermis, dermis, and the subcutaneous layers. In this section, we're going to talk about closed wounds. With closed wounds, they have internal injuries with no pathway from the outside to the injured site. Although the skin is unbroken, it may be extensively crushed tissue beneath. So it ranges from very minor to very life-threatening injuries. Contusions or a bruise is what you will see, and hematomas. Similar to a contusion, you'll have more tissue damage, and it involves larger blood vessels. So remember, in a closed wound, the skin has not been broken. Blunt trauma causes closed wounds. There are three types of closed wounds: contusions, hematomas, and crush injuries. The next closed wound is a crush injury. There's force that's transmitted from the exterior to the interior structures. The crush or rupture internal organs, when your solid organs bleed severely and cause shock, where your hollow organs leak into the body cavities. So closed injuries include contusions, ruptures of a hollow organ, internal laceration and puncture, crush injury with no open wound, and injury of a solid organ. For your patient assessment, bruising may be an indication of internal injury or internal bleeding. You want to consider the mechanism of injury, and crush injuries are very difficult to identify. Just remember that ecchymosis is a sign that blood vessels have broken under the skin. You want to take appropriate standard precautions, manage the airway, breathing, and circulation, and manage as if there were internal bleeding and shock if there is any possibility of internal injuries. You want to splint extremities that are painful, swollen, or deformed. Stay alert for vomiting. Continuously monitor for changes and transport promptly. Apply a cold pack to isolated injuries to manage pain and swelling. In this section, we're going to talk about open wounds. Types of open wounds include abrasions, lacerations, penetrating trauma and punctures, avulsions, and amputations. It also includes open crush injuries, bite wounds, blast injuries, and high pressure injection injuries. Let's think about it. Does an open wound necessitate using more than just gloves as a standard precaution? And can an open injury affect the patient's airway or breathing? So remember, open wounds may require more than just a glove as standard precautions, especially if they are spurting blood or if there's a potential to get blood or any other body fluids on your clothing or in your face. An open injury to the face, neck, chest, or spine could affect the airway and breathing depending on the location of the injury and the structures that were damaged. Emergency care for open wounds. You want to pay strict attention to standard precautions. In addition to wearing gloves, a gown and protective eyewear may be required. During your patient assessment, you want to do your primary assessment, checking the airway, breathing, circulation, and any severe bleeding, and then care for any individual wounds. You want to expose the wound, clean the wound surface, control any bleeding. For all serious wounds, you want to provide care for shock, including administration of high concentration oxygen, and prevent further contamination. Remember, controlling hemorrhage, recognizing and treating shock, preventing infection, and bandaging are important elements in the emergency care of an open wound. Bandage dressings in place after bleeding is controlled. Keep the patient lying still and reassure the patient. Next, we're going to talk about treating specific types of open wounds. Treating abrasions and lacerations. First, you want to reduce wound contamination. Hold direct pressure to control bleeding. Always check the pulse, motor, and sensory function distal to the injury to assure function. Treating penetrating trauma. You want to use caution because objects may be embedded deeper than they appear. Check for exit wounds, and it may require immediate care. Bullets can fracture bones as they enter. Stab wounds are considered serious, especially if in a vital area of the body. Remember that puncture wounds are particularly dangerous as they present only with small external wounds, but may damage structures deep into the body. You want to reassure the patient, search for any exit wounds, assess the need for basic life support, follow your local protocols regarding spinal motion restriction, and transport that patient immediately. So remember in your treatment that bullets travel in an unpredictable path once they are inside the patient's body, and they can therefore cause damage to multiple organs and bones. Here you will see a gunshot wound to the right flank. So think about where that bullet could travel and the organs and the internal injuries that that bullet could cause. Treating impaled objects. First, you do not remove the object. It may cause more severe bleeding. You want to expose the wound area. Control profuse bleeding by direct pressure. Get a description of the object and apply several layers of bulky dressing so dressing surrounds the object on all sides. Again, remember, do not remove or apply direct pressure to impaled objects. Place bulky dressings on the opposite side of the object. Secure the dressings in place. Care for shock, keep the patient at rest, and transport the patient carefully and as soon as possible. Always reassure the patient throughout all aspects of your care. Here you want to stabilize an impaled object with a bulky dressing. Here it shows that they are bandaging the impaled object and the surrounding dressing in place. Next, we'll talk about object impaled in the cheek. Objects may enter the oral cavity, causing airway obstruction. If the cheek wall is perforated, profuse bleeding into the mouth and throat can cause nausea and vomiting. External wound care will not stop the flow of the blood into the mouth. You want to examine the wound site, both inside and outside of the mouth. If you find the perforation and can see both ends, remove the object. If this cannot be easily done, leave the object in place. Here they are showing the process of removing an impaled object from the cheek. You want to position the patient to allow for drainage, monitor the patient's airway, dress outside of the wound, and consider the need for oxygen and care for shock. Puncture wound or object impaled in the eye. First, you want to stabilize the object. Apply rigid protection, and have another rescuer stabilize the dressing and cut while you secure them in place with self-adherent roller bandage or wrapping with the gauze. Here they're showing you how to manage an object that is impaled in the eye. Here they're showing you that the object is contained and immobilized. You want to dress and bandage the uninjured eye. Consider the need for oxygen and care for shock. You want to reassure the patient and provide any emotional support. Treating avulsions. You want to clean the wound surface, fold the skin back into the normal position, control bleeding and dress with a bulky dressing, and if avulsed parts are completely torn away, you want to save in sterile dressing and keep moist with sterile saline. Remember, emergency care for avulsions require the application of large, bulky pressure dressings. You want to preserve any avulsed parts and transport them to the medical facility along with the patient. Treating amputations. First, you want to take the steps to control any hemorrhage immediately. Apply direct pressure to control bleeding, and use a tourniquet only if all other methods fail. Here they're showing you how to care for an amputated part. The amputated digit sits on sterile gauze, awaiting re-implantation at the trauma center. You want to wrap the amputation site in sterile dressing and secure dressing with self-adhesive gauze bandage. Then wrap or bag the amputated part in a plastic bag. Keep it cool by cold packs. Do not immerse the amputated body part directly into water or saline. Remember, you always want to take care to treat amputated parts carefully, as there may be a possibility of reattachment. Treating genital injuries. First, you want to control the bleeding. Preserve avulsed parts. Consider whether injury suggests another possible, more serious injury. Display calm professional manner. Dress and bandage the wound, and consider the possibility of sexual assault. In this section, we're going to talk about burns. Burns may involve more than just the skin level structures. If respiratory structures are affected, swelling may occur, causing life-threatening obstructions. Do not let burns distract you from the spinal damage or fractures. So remember, burns involve immediate destruction of tissues, but can also have long-term effects, both physically and emotionally. During your assessment, you want to classify the burns, the agent and the source, the depth, and the severity. So remember that burns can be classified and evaluated in 3 different ways: by the agent and source, by the depth, and by the severity. Classifying burns by agent and source. Agent could be chemicals or electricity. Report the agent and, when practical, the source of the agent. Never assume the agent or the source of the burn. Always gather information from your observations of the scene, bystander reports, and the patient interview. Burns are classified by depth, and this gives you an idea. So the first one is superficial, the second one is partial thickness, and the third one is full thickness. Your superficial burn is your first-degree burn. It involves only the epidermis. It's reddening with minor swelling. Partial thickness burns are second degree. The epidermis is burned through and the dermis is damaged. They have deep, intense pain. It's noticeably reddening, blisters, and mottling. So remember, again, there's 3 classifications of burn depth that are superficial, partial thickness, and full thickness. Here's what a superficial burn looks like. So it's essentially like a sunburn. Here is a partial thickness burn. Here's another partial thickness burn. And then your full thickness burn is your third-degree burn, where all layers of the skin are burned. They have blackened areas or dry and white patches. Here is a full thickness burn. Determining the severity of burns. So you want to consider all the following factors: the agent or source of the burn, the body regions burned, the depth, the extent, the age of the patient, and other illnesses and injuries. Next is the rule of 9s. It helps estimate the extent of the burn area. The adult body is divided into 11 main areas. Each represents 9% of the body surface. So remember, the amount of skin surface involved in a burn can be calculated quickly by using the rule of 9s. So here you can see the rule of 9s on the adult, the child, and the infant. So just remember that each arm totals 9%. So the front of the arm is 4.5%, the back of the arm is 4.5%. The rule of palm is another way. It helps estimate the extent of the burn area. The palm and fingers equal about 1% of the body's surface, and it's easier to apply a smaller or localized burns. But remember, this is not your palm, this is the palm of the patient. The palm and the fingers of the patient is 1% of the body. So when classifying burns by severity, it must be classified to determine the order and the type of care, the priority for transport, the maximum information to provide the emergency department. For a pediatric note, infants and children have much greater relationships of body surface area to total body size, resulting in greater fluid and heat loss from the burned skin. Patient care for thermal burns. You want to stop the burning process and cool the burned area. Ensure an open airway and assess breathing. Look for signs of airway injury. Complete your primary assessment and treat for shock. Remember, there are special approaches to care for thermal burns, general chemical burns, and chemical burns to the eyes. So you should know the procedures for treating each type. You want to evaluate the burn by depth, extent, and severity. Do not clear debris. Remove clothing and jewelry. Wrap with dry, sterile dressing. For burns to the hands or feet, you want to remove the patient's rings or jewelry and separate the fingers or toes with a sterile gauze pad. Patient care for chemical burns, you want to wash away any chemical with copious amounts of flowing water. If it's a dry chemical, you want to remove contaminated clothing and then flush with water. You want to apply sterile dressings, treat for shock, and then transport. Next is radiation burns. You have exposure to high levels of radiation, which can harm the human body both immediately and in a delayed fashion. You have a great number of sources of radiation. It's difficult to detect without specific monitoring equipment. It can be extremely harmful. Do not approach a radiologic injury without protective equipment and specialized training. See the patient with a radiological burn only after they have been decontaminated. Most will likely present with thermal injuries. In this next section, we're going to talk about electrical injuries. So remember, safety is key. Electrical injury scenes are extremely hazardous to the emergency responders. Electrical injuries. Severe damage through the body along the pathway of the electrical current. Entry and exit burns are possible. Respiratory and cardiac arrest are possible. And bones may fracture from violent muscle contractions. So remember, the scenes of injuries due to electricity are often very hazardous. You want to assume that the source of electricity is still active unless a qualified person tells you that the power has been turned off. Electrical current can damage tissue in a variety of ways. Burns, nerve damage, and chemical changes are examples of the destruction that electricity can actually cause. So specific assessment findings can indicate the presence of electrical injuries. You want to provide airway and breathing care, provide basic cardiac life support, and be ready to defibrillate. Care for shock and administer high concentration of oxygen. Remember, proper care for electrical injuries must include treatment of cardiac dysrhythmias. In addition, spinal motion restriction should be considered. You want to care for any spinal and head injuries as well as extremity fractures. Evaluate the burn sites. Cool the burning areas and smoldering clothing the same as you would for a flame burn. Apply sterile dressings and transport as soon as possible. In this next section, we're going to talk about dressings and bandaging. Dressings and bandaging. First, we'll start out with dressing. It is any material applied to the wound to control bleeding and prevent contamination. Next is bandage. It's any material used to hold the dressing in place. So remember, a dressing is any material that is applied to the wound in an effort to control the bleeding and prevent further contamination. Where a bandage is any material that is used to hold the dressing in place. Here it shows dressing cover wounds. You have your universal dressing, which is available for profuse bleeding and large wounds. Then you have your pressure dressing, which is used to control the bleeding. An occlusive dressing, which is used to form an airtight seal, and a wound to the abdomen, large neck veins, or open wounds to the chest. So remember, bandaging frequently exposes providers to bloodborne pathogens. EMT should always don the correct level of personal protection prior to beginning these procedures. Bandaging is secondary to hemorrhage control. So when necessary, stop the bleeding before you apply the bandage. Here is a bandage that's holding the dressing in place. When you dress open wounds, you want to take standard precautions. Expose the wound, use sterile or very clean materials, cover the entire wound, control bleeding by direct pressure and/or hemostatic agents or dressings to stop or slow the bleeding, and do not remove the dressings. Bandaging open wounds. You do not bandage too tightly or too loosely. Do not leave loose ends. Do not cover tips of fingers or toes because you must observe the distal skin color changes. And cover all edges of the dressing. Remember, completely cover the wound with the dressing. Apply the bandage over the dressing and completely cover the dressing. Here they're showing to apply a self-adhering roller bandage. Secure it with several overlapping wraps. Here you want to apply the self-adhering roller bandage and keep it snug. All right, let's go through the chapter review. Soft tissue injuries may be closed, internal with no pathway to the outside, or it could be open, which is an injury in which the skin is interrupted, exposing the tissues below. Closed injuries include contusions or bruises, hematomas, crush injuries, blast injuries. Open wounds include abrasions, lacerations, punctures, avulsions, amputations, crush injuries, and blast injuries. For open wounds, you want to expose the wound, control the bleeding, and prevent further contamination. For both open and closed injuries, you want to take appropriate standard precautions. Note the mechanism of injury. Protect the patient's airway and breathing. Consider the need for oxygen by non-rebreather mask. And treat for shock and transport. Burn severity is determined by considering the source of the burn, body regions burned, depth of the burn, superficial, partial thickness, or full thickness. Extent of the burn by rule of nines or rule of palm. Age of the patient. Children under 5 and adults over 55 react most severely, and other patient illnesses or injuries. Care for burns includes stopping the burning process, using water or a thermal burn, brushing away dry chemicals, covering a thermal burn with a dry, sterile dressing, flushing a chemical burn with sterile water, protecting the airway, administering oxygen as appropriate, and treating for shock and transporting the patient to a medical facility. For treatment of electrical injuries, be sure that you and your patient are in a safe zone away from the possible contact with electrical sources. Protect the airway, breathing, and circulation. Be prepared to care for respiratory or cardiac arrest. Treat for shock and care for burns and transport the patient. Remember, the soft tissue of the body is made up of skin, fatty tissues, muscles, blood vessels, connective tissues, membranes, glands, and nerves. The skin provides protection, water balance, temperature regulation, excretion, and shock absorption. Open or closed in reference to a soft tissue injury is dictated by whether or not the skin is still intact. Closed injuries must be evaluated with consideration to underlying anatomy and mechanism of injury. Open injuries typically are easier to visualize, but they can often mask underlying injuries. Burns involve immediate destruction of tissue, but also can have a long-term effect, both physically and emotionally. Safety must be a key concern when treating a patient with a burn or an electrical injury. The goal of the dressing and bandaging wounds is to control bleeding and to prevent infection. Questions to consider. Does the patient have a patent airway and is breathing adequately? If the wound is penetrating, is there an exit wound? And what is the best way to immobilize an impaled object? Is there respiratory involvement with the burn? Have we irrigated the chemical burn sufficiently? Does the electrical burn have an exit wound? Is the bandage securely fastened to hold the dressing? So you have a 21-year-old male lacerated his anterior elbow when he fell through a window. There is a lot of blood around the patient. Bystanders have applied numerous towels and the washcloths over the wounds. It's at least 3 inches thick. There are so many dressings on the wound that you can't tell if it's still bleeding. The patient is alert but pale and anxious. The radial pulse on his uninjured arm is weak and rapid. How much assessment of the wound should you do, and how do you do it without making things worse?